Hi everyone. Today's topic is physiology of pregnancy. Let us discuss it under the following headings: Introduction, Fertilization and Implantation, Physiological changes during pregnancy, Physiology of Parturition in pregnancy tests. Physiology of pregnancy is mainly concerned with the maternal adaptations to provide ideal atmosphere for fertilization, nutrition to the growing fetus, safe childbirth, and also to fulfill the nutritional needs of the newborn. We know that mainly it is the reproductive system which is involved in the pregnancy, but the other body system also has to undergo the adjustments. Fertilization, it refers to the fusion of male and the female gametes, which takes place in the middle segment of the fallopian tube, which is the ampulla. So fertilization involves the following events: the transportation of ovum, transportation of sperm in the female genital tract, sperm capacitation, fusion of the gametes, and activation of the ovum. Let us discuss the following events one by one. Transportation of ovum. At the time of ovulation, the ovum is directly expelled into the peritoneal cavity and then it enters into the fallopian tubule. How it enters, let us see. There are fimbriae of the fallopian tube and that is internally lined by the ciliated epithelium. When ovulation occurs, the fimbriae of the infundibulum it encircles the surface of the ovary. It rubs it and it picks up the ovum and then it directs it towards the ostium just by beating continuously the cilia. So the contractions of the smooth muscles present in the wall of the fallopian tubule helps in the transport of the ovum. These contractions are increased mainly at the time of the ovulation. Structure of the ovum. The released mature ovum consists of oocyte, which contains 23 unpaired chromosomes surrounded by the inner membranous layer called zona pellucida, consisting of glycoproteins on its outer side, surrounded by corona radiata, consists of granulosa cells, which is arranged in multiple layers. So these cells are held together by matrix composed of hyaluronic acid. Fate of ovum. The ovum is held up at the ampulla. There is a systemic junction for 2 to 3 days. It remains viable for 6 to 24 hours after ovulation. So during this period, if viable sperm penetrates, then the fertilization takes place and that leads on to the pregnancy. And if fertilization doesn't happen and then the ovum dies and it degenerates and the menstruation occurs. Transportation of sperm in the female genital tract. So after the ejaculation, several million sperms, so that is around 200 million sperms, that gets deposited in the vagina. So out of these, only 50 to 100 sperms manage to reach the ovum, and only one is able to penetrate it. So this is because there are several factors that affect the transportation, and the accessibility of the sperm happens to the ovum. You can see when 200 million tries and only one able to reach the ovum finally. Motility of sperms. So after ejaculation, normal sperms, they shows flgellar movement in the fluid medium at the rate of 1 to 4 millimeter per minute. So therefore 30 to 60 minutes they will be able to reach the fallopian tube. So this motility of the sperm, it depends on the pH of fluid medium, cervical mucus secretions, fluid currents, temperature, and the hormones. pH of fluid medium. Neutral and alkaline pH enhances the activity of the sperms, but it is greatly depressed even in mild acidic medium. We know that vaginal fluid is acidic, so immediately the sperm activity after reaching the vagina, it is inhibited. In sperms, it becomes non-motile. So the alkaline semen, it neutralizes the vaginal acidic fluid. So in less than 60 minutes after ejaculation, sperms again it becomes active, and their activity increases in the cervix and then in the body of the uterus for the next 24 to 40 hours. Cervical mucus secretion. Cervical secretion, it acts as a mechanical barrier for the sperms. The nature of the cervical secretion depends on the hormonal secretion in the plasma during proliferative phase of menstrual cycle and at the end of the ovulation. So under the influence of estrogen, the cervical secretion becomes thin and watery, which favors the passage of the sperms. Morphologically, the abnormal sperms, they cannot pass through the cervical mucus barrier and they get entrapped within the fluid. Fluid currents. Vaginal and uterine cavity represents a vast sea in which currents are set up by the ciliary movements towards the exterior, that is the antagonist direction, which further resists the sperm motility. And temperature, with rising temperature, the activity of the sperm increases, but their lifespan is shortened. In the ejaculated semen, the maximum lifespan of sperm is 24 to 48 hours at the body temperature, but at lower temperature, however, the sperm can be stored for several weeks, and at minus 100 degrees Celsius, sperms can be preserved for many years. This is how the sperm bank is functioning. They store the sperm for lifelong when they store it at minus 100 degrees Celsius. Hormones. Local release of hormones as well as high concentration of certain hormones in the blood, they affect the sperm transportation. Oxytocin during coitus, the stimulation of the female genitalia leads to reflex release of oxytocin from the neurohypophysis. So oxytocin that causes propulsive movements of the uterus, which helps to aspirate the seminal fluid from the vagina into the fallopian tube. And then the estrogen, it makes the cervical secretion thin and watery, which favors the transport of the sperms. Prostaglandin, it is present in the semen, which is contributed by the seminal vesicle fluid, also increases the female genital tract movements. And then progesterone after ovulation, progesterone present in the follicular fluid is released, which further stimulates the sperm motility. Sperm capacitation, it is the process that makes a sperm to fertilize an ovum. Immediately after ejaculation in the female genital tract, the sperm undergoes certain changes which enables it to fertilize the ovum. It takes around 1 to 10 hours, that is the capacitation period. Sperm capacitation occurs due to removal of certain factors which normally remain silent when it is in the male genital tract. The cholesterol content of the acrosomal membrane. So in the male genital tract, the acrosomal membrane remains very tough and because of high cholesterol content. Whereas when it reaches the female genital tract, the cholesterol content of the acrosomal membrane decreases and it becomes weak, leading to easy release of enzymes from the head. The membrane of the sperm becomes permeable to the calcium ion. The influx of the calcium acts by two ways. One, it makes the flagellar movement of the sperm more strong and whippish, that is hyperactive. And secondly, it triggers the release of the enzymes from the acrosome. The fusion of the gametes happens with the following events. The first one is the hemoattraction, and then penetration of sperm through ovum covering, and then fusion of sperm with the oocyte. Hemoattraction. So hemoattraction of the sperm to the ovum occurs by the substances produced by the ovum. Penetration of sperm through the ovum coverings. The sperm passes through two layers, there is the corona radiata and zona pellucida, before it reaches the ovum. So the penetration of corona radiata, it is made possible by the release of the enzyme hyaluronidase and other proteolytic enzymes which is present on the acrosome of the sperm, and also the hyperactivation of the sperm that causes it. The hyaluronidase that polymerizes the hyaluronic acid which is present in the intercellular matrix holding the granulosa cells. The proteolytic enzymes that digest away the proteins of the structural tissues. And then the hyperactivation of the sperms, that is the increased flagellar movement that produces the penetrating thrust on the ovum due to vigorous slashing of the sperm's tail. And through the second layer, that is the zona pellucida, So after passing through the multilayered granulosa cells, that is the corona radiata, many sperms may contact with the zona pellucida by binding to the receptor protein called zona pellucida glycoprotein, which is EZP3. So the binding of the sperm to the zona pellucida glycoprotein that triggers the acrosomal reaction. So acrosomal reaction involves the release of acrosin, which is a protease enzyme from the anterior membrane of the acrosome. So this acrosome opens the penetrating pathway for passage of sperm head into the perivitelline space, that is the space between the zona pellucida and the oocyte membrane. For effective penetration by the sperm, the acrosomal reaction takes place at the zona pellucida because the lifespan of the acrosomal reacted sperm is very short. If it takes place outside the zona pellucida, the sperm cannot pass through this membrane. So the acrosomal reaction is also very important for the actual fusion of sperm cell with the oocyte membrane. Fusion of sperm with the oocyte. The equatorial region of the acrosome is considered to be the site of initial contact between the sperm and the oocyte membrane, that is the vitelline membrane. Fertilin is a protein which is present on the acrosomal reactor sperm, which interacts with the protein which is present on the vitelline membrane, and within 30 minutes the membrane of the sperm and the oocyte they fuse, and the genetic material of the sperm enters into the oocyte, and that causes the fertilization, and the embryo begins to develop. So this fertilin protein reacting with the protein on the vitelline membrane is very important for the fusion. Activation of ovum. Only one sperm can enter into the oocyte, and further entry of the sperm is prevented just by the activation of the ovum. So the fusion of the membranes of the gametes leads to the ovum activation, so which involves the membrane potential of the ovum decreases, which is followed by some structural changes in the zona pellucida, and then the release of calcium from the intercellular ovum reserve that leads to exocytosis of the cortical granules, which is present near the oocyte membrane, into the perivitelline space. Vitelline block to polyspermy. The spread of cortical granules along the perivitelline membrane prevents the further entry of the sperm into the ovum. So this is called as the vitelline block to polyspermy. So it will not entertain many sperms to enter into a single ovum. So the proteins in the cortical granules into the perivitelline membrane plays a major role. And zona blockade to the polyspermy. Cortical granules contain certain substances like glycosidases and proteases. The glycosidases that causes alteration in the zona pellucida glycoprotein, receptor protein of the zona pellucida. In proteases, they degrade the zona pellucida glycoprotein itself. So both these mechanisms causes the loss of affinity of sperm for the zona pellucida, and thus that prevents the polyspermy. So this is called as the zona block to the polysperm. Implantation of a fertilized ovum happens with the following events. First is the formation of the blastocyst. The fertilized ovum starts dividing immediately, and it is called as morula, which is a 16 cell stage, and then into the blastocyst, which is the 100 cell stage. So this one, the inner cell mass surrounds by a layer of cells which is called as trophoblast, which is covered by the zona pellucida. The trophoblast cell layers are very sticky and has the affinity towards the epithelial cells of the fallopian tube. As this blastocyst is covered by the zona pellucida, the trophoblasts are not exposed, and so the blastocyst is usually not implanted in the fallopian tube. So the presence of the zona pellucida layer prevents the implantation in the fallopian tube. And then transportation of blastocyst in the uterine cavity. In the next 3 to 4 days, the blastocyst is transported into the cavity, uterine cavity. The transportation is assisted by fluid currents and also the ciliary movements of the epithelial cells of the fallopian tube and the uterus. The cavity of the uterus, the blastocyst flows for some time, and by this time the zona pellucida layer disappears and the trophoblast cell layer is exposed. Implantation of blastocyst in the endometrium. The blastocyst then erodes and the burrows into the endometrium. The blastocyst goes deeper and deeper into the uterine mucosa till whole of it lies within the endometrium. And then the residual reaction after implantation, the endometrium is called residua. The stroma cells of the endometrium that gets enlarged, it becomes vacuolated and gets filled with the glycogen and lipids. So these cells are called residual cells. So the stored glycogen and the lipids are the main source of nutrients for the embryo till the placenta takes up this function. This change in the stroma cell is called as the residual reaction. The stored glycogen is the source of nutrition for the embryo. Physiological changes in mother during pregnancy. Normal average duration of pregnancy in human is 40 weeks, approximately 240 days, and it is calculated from the first day of the last menstrual cycle. As the pregnancy progresses, the various types of demands are exposed on the mother's body by the fetus. So, which is done with adaptation in most of our body systems. The physiological changes include the changes in the genital organ, weight gain, hematological changes, cardiovascular changes, respiratory changes, urinary system changes, gastrointestinal changes, metabolic changes, endocrine changes, and the changes in the skin. Let us discuss one by one. Changes in the genital organ includes changes in the uterus, ovaries, cervix, fallopian tube, and the mammary glands. Uterus, to accommodate the growing fetus, there will be marked increase in the size of the uterus. Enlargement is mainly due to the hypertrophy and also hyperplasia of the myometrial smooth muscle fibers. The amount of connective tissue and the elastic tissue in between the muscle fibers, that also increases. Weight increases from 30 to 50 gram to 1000 to 1200 grams. Length increases from 7.5 centimeter to 35 centimeter at term. Thickness of the wall of the uterus decreases from 1.25 centimeter to only 5 millimeter at terms, and the fetus can be palpated through it. And volume of the uterus increases from 1.25 from few ml to about 5 to 7 liters a term. Mainly this is due to the fetus, placenta, and also the amniotic fluids. Shape changes from the piriform to the globular. Ovaries, the corpus luteum enlarges during first 12 to 16 weeks of pregnancy and then degenerates due to the decreased level of human chorionic gonadotropin hormone. And by this time, placenta takes over the function of secretion of estrogen and the progesterone. The follicular changes in the ovulation do not occur because FSH and the LH of anterior pituitary, they are inhibited. Cervix, the endocervix gets hypertrophied, cervical glands increase in number, and their secretions form a plug that closes the cervical canal. Tough cervix becomes very soft. Fallopian tubes. So fallopian tubes are pushed upwards due to increase in the size of the uterus. Hyperplasia of the epithelial cells and blood supply also increases. Mammary gland, under the influence of various hormones, breast enlarges in early pregnancy. Hyperplasia of ductal and the alveolar tissue happens. The areola becomes pigmented and many sebaceous cysts become prominent in the areola. Nipple also becomes larger and pigmented. So the estrogen plays on the ducts, and you can see the progesterone it plays on the uh, alveolar tissue. So the estrogen and the progesterone acts under the influence of the prolactin. Weight gain. Total weight gain during normal pregnancy is 10 to 12 kilograms, so which is contributed by the fetus by 3 kilograms, placenta and amniotic fluid 1.5 kilogram, uterus and breast enlargement 1.5 kilograms, blood volume in the interstitial fluid 1.5 kilograms, fat deposition 3 to 4 kilograms. So this weight has to be monitored throughout the pregnancy. It has to be very regular and it is very important. Even the if the weight gain is not there in the second and the third trimester, it is a sign of the fetal growth retardation which we have to look for. So in the early pregnancy, if there is a weight loss, that may be due to excessive vomiting and due to decreased secretion of the estrogen, progesterone, aldosterone, and the antidiuretic hormone. So during the pregnancy, the sodium and the water retention may happen, which may lead on to excessive weight gain. And edema is common due to this, and particularly in the lower limb. So that is because of the sodium and water retention. So rapid and excessive weight gain, which we have to suspect the toxemia of the pregnancy. So weight gain monitoring is very important during pregnancy. Hematological changes. The blood volume increases during pregnancy to increase the blood supply to the uterus, skin, and to the kidney. The total blood volume increases by 30%. It begins to increase by the 12th week of the pregnancy and that continues till the delivery. The plasma volume increases relatively more than that of the red cell volume, which causes the hemodilution, and that is the cause for the physiological anemia of pregnancy. The hematological indices, there is different changes. The blood indices decreases, plasma protein decreases, the total concentration of the plasma protein decreases from 7.5 to 6 grams percentage, that is due to the hemodilution. The fibrinogen level increases, serum albumin is markedly decreases, and globulins they increases. Leukocytes it increases and it may reach up to 20,000 per cubic millimeter. And then platelets, so there will be slight decrease in the platelet count. Coagulation factors, so pregnancy seems to be a hypercoagulable state, so due to the increase in the coagulation factors, the fibrinogen factor 7, 8, 9, 10 all increases. So the hypercoagulability of the blood plays significant role of hemostasis at the time of separation of placenta during the pregnancy. CVS changes. Position of the heart. The gravid uterus pushes the diaphragm upwards, resulting in the change in the position of the heart. So heart is displaced laterally upwards and slightly rotated to its long axis. So apex of the heart that shifts laterally because of the changes in the heart position. ECG changes shows the left axis deviation. Heart rate also increases by 10 to 12 beats per minute. Cardiac output increases from 5 liters to 7 liters at the 20th week of pregnancy. The increase in the cardiac output is due to increase in both the stroke volume and heart rate during the pregnancy. And then the blood pressure. Systolic blood pressure in normal pregnancy, there is either no change in the systolic pressure or there may be some fall in it. Diastolic blood pressure decreases by 16 to 20 weeks of pregnancy. It is much lower and then it starts rising and come back to normal. So vasodilatation due to the effect of vasoactive substances is the main cause of fall in the diastolic blood pressure. And the blood flow to the skin, uterus and kidney increases due to the increase in the demand. And then the venous pressure. So the gravid uterus exerts the pressure on the pelvic veins, abdominal veins and the femoral veins. So the increasing the venous pressure. The rise in the femoral venous pressure results in edema in the feet and increased abdominal venous pressure. So that causes the varicose veins, piles, and peripheral venous thrombosis later. RS changes, anatomical changes occur due to the elevation of diaphragm and that causes increase in the transverse diameter of the thoracic cage and also the subcostal angle. So these two changes in turn that increases the airflow across the bronchial tree. Hyperventilation, high levels of plasma, progesterone during pregnancy increases sensitivity of respiratory neurons to carbon dioxide, which results in hyperventilation. Ventilatory functions, so the anatomical changes in the hyperventilation during pregnancy result in the change in the ventilatory functions and its parameters. Tidal volume increases, there is no change in the vital capacity. Inspiratory capacity increases, residual volume decreases, functional residual capacity decreases, forced expiratory volume and peak flow rate they do not change. Gas exchange, so across the alveoli is greatly enhanced due to the marked increase in the pulmonary blood flow. And then oxygen consumption of body increases by 50%, 15% to meet the demand. The renal changes. Renal blood flow increases markedly due to the increase in the cardiac output and the vasodilatation. Effective renal plasma flow increases by 60%. And then the glomerular filtration rate in the renal increases by 50%. And renal tubular absorptive capacity for sodium and chloride ions increases by 50% due to the high level of steroid hormones secreted by the placenta in the adrenal cortex. Clearance rate of the substances like creatinine, urea increases. So the plasma creatinine and the plasma urea volumes decreases during the pregnancy. Glycosuria is a common physiological phenomena during the pregnancy. Proteinuria occurs due to increase in the excretion of protein. Water balance during later months of the pregnancy, excess of water is retained due to the decreased protein concentration. So that is albumin, so leading to decreased colloidal osmotic pressure. And then acid base acid base balance. Hyperventilation during pregnancy results in the respiratory alkalosis. The kidney that compensate for it by excreting more bicarbonates. Respiratory alkalosis shifts the hemoglobin oxygen dissociation curve of the maternal blood to left. So slight rise of pH of blood stimulates the formation of 2,3-DPG, which shifts the hemoglobin oxygen dissociation curve to right and facilitates oxygen transfer to the fetus. GIT changes. GIT secretions. The hypochlorhydria is very common due to decreased gastric secretion. Motility decreases under the influence of hormone, resulting in delayed gastric emptying. Gallbladder functions. Gallbladder increases in size and empties its content at a very slow rate. Liver functions gets altered. Fibrinogen synthesis increases, and the albumin gets decreased. Motion sickness, anorexia, nausea, and vomiting are very common in the early pregnancy, especially in the morning hours. So that is known as morning sickness. The cause for the morning sickness is not established. Glucose tolerance curve. So that shows the disturbance. So it becomes diabetic type due to glucose being rapidly absorbed from the intestine. Metabolic changes. The basal metabolic rate increases by 15% during the later half of the pregnancy. Protein metabolism, when the diet is balanced and adequate, then there is nitrogen retention and positive nitrogen balance. The proteins are deposited in the uterus, breast, and in fetus and in the placenta. Carbohydrate metabolism. So the blood glucose level increases due to rapid absorption from the gut. Glycosuria is common occurrence due to increase in the glomerular filtration rate and decrease in the renal threshold for the glucose. And then hepatic glycogen level decreases. Fat metabolism, about 3 to 4 kg of fat is deposited in the body. So there will be increase in plasma concentration of cholesterol, triglycerides, and the phospholipids. Mineral metabolism, calcium and phosphorus in normal pregnancy. It retains about 50 grams of extra calcium and 30 to 40 grams of phosphorus. These are deposited in the fetus and also retained in the mother stores, that is in the skeletal muscle. These stores act as reservoir for the extra demand of calcium during the lactation period. During pregnancy, deficiency of calcium, because normally its absorption is very poor. Dietary supplementation of calcium is very important along with the vitamin D. Endocrine changes. Almost all the endocrine glands react during the pregnancy. First, due to increase in the metabolic load, and secondly, in response to the hormones produced by the placenta and the fetus, other endocrine glands reacts. Anterior pituitary. So the anterior pituitary gland increases in size by 50% and shows the hyperplasia of the lactotrophs. Prolactin level increases progressively throughout the pregnancy under the influence of high level of estrogen, and then the ACTH increases. Growth hormone decreases. This is due to the suppression of chorionic isoform. And then the gonadotropins and the sex hormones under the influence of high concentration of estrogen and the progesterone. The secretion of FSH and the LH is suppressed. So the low concentration of FSH and LH inhibits the maturation of Graafian follicles in the ovaries. Thyroid stimulating hormone, the TSH concentration also increases. And then posterior pituitary, oxytocin secretion is inhibited during pregnancy because of the high levels of estrogen and progesterone, but its level gets increased during the labor. Antidiuretic hormone increases during the pregnancy, and then thyroid, the size and the secretory activity of the thyroid gland increases during the pregnancy, and thyroid binding globulin increases, which in turn increases the bond fraction of T3 and T4. Parathyroid hormone shows increase in its size and also in its secretion. So the rise level of parathyroid hormone increases the activation of the vitamin D, D3, and vitamin D3 binding protein. Adrenal cortex. So the adrenal cortex gets enlarged during pregnancy, and also there is increase in the width of the zona fasciculata, and the concentration of glucocorticoids, which is responsible for the deposition of fat in the adipose tissue and the appearance of the stria. Aldosterone secretion increases progressively and reaches up to 6 to 8 folds of the term. Normal pregnancy is also associated with the increased secretion of angiotensinogen, renin, and several tensinogen, which includes angiotensin 2. Other mineralocorticoids and deoxycorticosteroids are increased. Pancreas, there is beta cell hyperplasia leading to increased level of insulin secretion, but the maternal tissue is sensitive to the insulin and is variable during pregnancy. So that increases in the first half and decreases in the second half of the pregnancy, which may result in the insulin resistance. Skin changes. So hyperpigmentation occurs on the face, that is the butterfly pattern plasma and areola nipple in the midline of the abdomen extending from the pubic symphysis. So hyperpigmentation is related to the increased secretion of ACTH and the melanin secreting hormone during the pregnancy. And then stria gravidum. So these are the linear lines which are present on the lower abdomen. Psychological changes. Nervous system shows mild changes in the form of carving for particular type of food item, alteration in the behavior, emotions, and mood. In few cases, true psychosis may also develop, but the cause is not known. Parturition is the process by which the baby is born. So parturition is a process by which the fetus, the membranes, and the placenta are expelled from the uterus. Progressive hormonal and the mechanical changes result in a strong rhythmic contractions. It is also called as labor. Initiation of labor. There are three stages. At the end of about 40 weeks of gestation, uterine contractions begin. Initially, there are weak and painless contractions, that is the Braxton Hicks. Then the intermittent contraction become painful and there will be increase in the frequency, duration, and the force. And then the cervix dilates. So there are three stages of labor. The first stage of labor, so from the beginning of painful contractions of the uterus to full dilatation of the cervix, there is a first stage of labor. At this time, the membranes rupture. There is a rupture of the amniotic sac, and the amniotic fluid is expelled. This stage lasts for about 16 hours. Second stage of labor. This is the stage that begins with complete dilatation of the cervix. Fetus gradually passes down the dilated canal by merging of the uterus, cervix, and the vagina as a single broad channel. Finally, the fetus is delivered. Voluntary contraction of the abdominal muscles and diaphragm and straining, it all assists in the delivery. Stage 3 of labor, expulsion of the placenta, which follows a few minutes after the delivery of the fetus, followed by delivery. There is a beginning of uterine contraction. Here you can see the placenta after the expulsion, and here you can see the umbilical cord in the uterine artery and the vein. Here you can see vein and the arteries. Let us see the changes following the parturition. So after parturition, there is involution of the uterus in the pelvic organs. Postpartum period of about 6 weeks is called as the purpurium. So over it takes 3 months for the maternal system to return to the pre-gravid state, and this sometimes it is called as the fourth trimester. Mechanism of parturition. At the end of pregnancy, the uterus is greatly distended, but the cervix is softened. As the labor begins, cervix dilates, afferent impulses travel up to the hypothalamus, and it increases the oxytocin release. More glucocorticoids with less androgen is will be there, and there will be fall in the progesterone. Oxytocin, it acts directly on the uterine smooth muscles, and it also happens by increasing the prostaglandin formation. Reduces the formation of progesterone and increases the estrogen, which leads to increased production of the prostaglandins. Let us discuss the mechanisms which is responsible for the onset of labor. The control of parturition includes the role of hormonal and the mechanical factors. Hormonal factors, the hormonal changes that initiates the parturition and cause increased excitability of the uterine musculature. So for that, the activation of the fetal hypothalamic pituitary adrenal axis. So recently they have hypothesized that the initial signals for the onset of labor comes from the fetus only, and due to some unknown factors, the corticotropic releasing hormone secretion in the fetus results in an increased ACTH secretion few days before parturition, and the ACTH causes the fetal adrenal cortex to secrete large amount of androgens. So changes these changes lead to an altered estrogen progesterone ratio. The role of altered estrogen progesterone ratio also causes an increase in the release of oxytocin from the maternal posterior pituitary. The increase in number of oxytocin receptor in the myometrium, and an increase in the prostaglandin synthesis. In this prostaglandin that enhances the force of oxytocin induced uterine contractions. And then the mechanical factors that increases the contractility of the uterine. So the stretch of uterine musculature usually increases its own contractility, that is the myogenic theory. As the pregnancy advances with the growing fetus, the stretch increases, leading to the uterine contractility. And then the positive feedback effect, stretching and the irritation of the cervix is particularly important because this positive feedback effect leads to further reflex increase in the uterine contractility, and this positive feedback mechanism continues until the baby is expelled. In the role of Ferguson reflex, and once the labor is started, the uterine contractions dilate the rib and cervix. The cervical dilatation in turn sets of signals in the afferent nerves that increases oxytocin secretion from the posterior pituitary, and this is called as the Ferguson reflex. Basis of pregnancy tests. During pregnancy, this human chorionic gonadotropin hormone is secreted by the placenta, seen only after 10 to 12 days after a missed period. This human chorionic gonadotropin hormone level peaks between 60 to 70th day of pregnancy. So direction of this hormone confirms the pregnancy. Pregnancy test. So laboratory test, the reduction of the human chorionic gonadotropin hormone in the serum and the urine based on the immunoassay techniques can be done, and radiological diagnosis can be made using the ultrasonography. Books to read: Hindukurana, Guyton and Hall, Genon, and Jeep K. Paul. Thank you.